I'm going to be speaking about supporting healthcare transition from adolescence to adulthood. I'll just give you a little bit of background. Having been a primary care pediatrician for over 12 years before I did a fellowship in developmental and behavioral pediatrics, I certainly understand from a primary care provider's perspective as well as a family's perspective how hard it is to do this in a 15-minute or a 20-minute appointment. This is a huge topic, and I think it takes a lot of time, a lot of effort on both families' parts and the provider's part. So I can certainly try and give you some guidance on how to do this efficiently and effectively and how to make it a seamless process for families, patients, and for providers. So today's learning objectives are understanding the healthcare transition process from both the family and the provider perspective. I wanted to address some of the barriers to healthcare transition, and I know most of us are quite familiar with those, but I'd just like to outline them for you, and also identify some practical ways to implement transition guidelines and identify some community resources. And I've given you a number of handouts which are out up front, so you could use those too, including some web resources. So some of the questions we ask are, how would you plan transition? How would you find an adult specialist or adult provider? What other issues should you consider when you're talking about healthcare transition, and how do you address these issues? And what community and online resources are available? So in the US, about 18% of youth have special healthcare needs, and when we say special healthcare needs, we mean children who have any kind of medical, emotional, developmental, or behavioral condition. So even someone with chronic asthma or somebody with autism, cerebral palsy, they all have special healthcare needs, so they need care over and beyond what a completely healthy adolescent would need. These needs actually, even though they are only 18% of the population, they actually count for about 80% of healthcare expenditures. So they're a huge expense for insurance companies as well as for Medi-Cal. And so a lot of attention is paid to their healthcare in the healthcare systems. Most of these youth, because of better healthcare and better facilities, are now surviving well into adulthood. And some of them function as effective community members, and they will receive care in an adult model at some stage in their lives. So we want to make this transition from pediatrics to adult medicine because once they reach adulthood, they're more likely to get adult diseases and adult healthcare conditions, and pediatric providers are not really trained to address those issues. That's why it's so important. When we think about transition, we want to think of it as an active process over time that not only addresses their medical issues, but also their psychosocial issues, educational issues, vocational needs, reproductive needs. I know you've had other talks on these topics, but I think it's important for providers to understand that you look at these youth as a whole person, not just their medical diagnoses. The goal of healthcare transition is basically lifelong functioning and well-being of all youth, and we want to do this transition in an uninterrupted manner. And the Maternal and Child Health Bureau defines healthcare transition as care being seamless, effective, and comprehensive for all youth and families. So why is it important for youth to be involved? Because they need to be at their center, at the center of their own healthcare. So they need to be advocates if they can be, and they need to take charge of being in charge of their own healthcare, including appointments, discussions with providers. Most special healthcare needs, even those who are not cognitively impaired, are very dependent on their care providers, and they really need to learn these skills as time goes on, and that's something I'm going to be talking about more. If they don't transition to adult healthcare, other things like reproductive needs and psychosocial needs often get missed, and that's really important for providers and families to address with their providers. A little bit of historical background. The transition movement really started around 2002 when the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians issued a consensus statement saying that this is an important area which providers need to address. Unfortunately, despite all this talk right from 10, 15 years ago, the last two national surveys of children with special healthcare needs. Now these surveys are actually phone surveys which involve thousands and thousands of families across the country from all sorts of backgrounds. And they talk about all the needs with special healthcare children have. And they found that only 40% receive any kind of services related to transition. This was in the last national survey, which was 2009 to 2010. And the previous survey in 2005, 2006 showed that 41% received these services. So really no change at all took place. The number was exactly the same. The DHSS Healthy People 2020 has labeled this as one of the national public health goals to have effective transition. And it's also one of the 6 performance priorities for the National Maternal and Child Health Policy. Now with the Affordable Health Care Act, so transition is considered an essential health service, and there's talk about providers being compensated or rewarded for providing effective transition services as part of their comprehensive care. So it is a high priority area in many national goals. So when we were talking about the national survey, so I said less than half of providers discuss transitioning to an adult provider, and only 1/3 of youth with special healthcare needs discuss this in California, discuss transition services. So the figures were even lower than the national figures. It's for minority youth in California or youth who have no medical home. It was as low as 22% of providers discuss this with their patients. And the rates are the lowest for those who have no insurance, who have no medical home, who are minority, who are below poverty level. And this is important for us, for youth with developmental, emotional, and behavioral conditions, because those are the ones who are most likely to stay on in pediatrics and not have that transition to adult healthcare or even have a discussion about it. Some of the barriers which I wanted to talk about, there is certainly limited staff and provider training. This is not addressed in most medical school or residency curricula. This is something that I have been trying to do at UC Davis, educate residents and medical students, because this is not even a required topic in their curriculum. So they basically get no training as far as the curriculum for students and residents. There is more awareness now, and I think the biggest gap is in provider training for those who are doing adult medicine. I think pediatricians get more training in this than adult providers do. Adult providers are basically not trained in taking care of childhood onset conditions like cerebral palsy or autism or spina bifida. They get very, very little training. There are some institutions in the country which are really trying to do this, but the vast majority get no training. Also, there's no identified person in a doctor's office responsible for transition. Often in those who do address this, it's usually a nurse manager or a case manager or a social worker. They're the ones who typically take charge of this if it happens. There's financial barriers. As you know, doctors are always rushed to see more patients, and they don't get compensated for extended appointments. So the healthcare system, unfortunately, is designed to keep appointments short and to see more patients, but not to provide comprehensive care. But there are ways around it, and I'll talk a little bit about that. There's also difficulty finding adult providers. There's fragmentation between primary and subspecialty care. This is a huge barrier because people often want experts in an adult doctor who's an expert in autism, or an adult doctor who's an expert in some genetic condition. And typically there are no such adult doctors. You as the parent or caregiver is the person who's most responsible for educating the adult provider, because you're not going to find experts in a condition typically. There's also a lot of anxiety on both the pediatrician's part, the family's part, and the patient's part about moving on from pediatrics. Everybody's used to a warm and fuzzy environment in peds where it's very family friendly. In the adult world, it's much more patient oriented and not so family oriented. And adult doctors just are not used to dealing with adult clients who might be cognitively impaired or physically impaired as much. There's also a lack of appropriate tools for addressing readiness for transition, but that's changing too, so there's some resources out there now. Lack of time, inadequate reimbursement, lack of research to identify best practices, lack of information on both the providers and the client's part about community resources, and many times it's the lack of the adolescents' knowledge about their own health or how to self-advocate for their own health. We talked about how adult healthcare has difficulty meeting the high expectations for time and attention, and also youth psychosocial needs. Youth are also, especially youth with special healthcare needs, they're less mature and less ready for decision making because somebody else has always spoken for them. This is also, as you know, adolescence is a time when there's less compliance, so it's often the case that somebody with a special healthcare condition is more likely to end up in the emergency room or be hospitalized rather than seek primary care. We talked about some of these other barriers. Adult providers often say the families don't feel comfortable coming to us. They want to go back to their old office. They feel awkward. And they can sense that. I've heard this from several adult providers in some transition conferences I've attended. So it's really important for them to make the families feel comfortable and also to educate themselves about those conditions. There's also lack of communication between pediatrics and adult medicine, and there are some ways around that too. So I'd like to show you a brief video. It is kind of over the top but fun to watch. I'd like to spend a few minutes talking about what a patient-centered medical home is. Are you all familiar with that concept? So it's actually a relatively new way of delivering comprehensive primary care to children, adolescents, and adults. And there are some basic tenets, like it's supposed to be patient-centered, so you respect the patient's needs, wants, preferences, patients or families. It's comprehensive, which means that you take care of not just the physical needs, but also chronic care, acute care, coordinating with subspecialists. It's coordinated, so it's across all systems of healthcare, including hospitals, ERs, home healthcare, community services. It's accessible, which means that you have access to doctors, to urgent care, to after hours. Basically, it's supposed to be 24/7, and most importantly, it's committed to quality and safety. So there are certain criteria you can use to label yourself a patient-centered medical home, and the doctor is supposed to work in partnership with the youth and family to assure that all their medical and non-medical needs are met. So this is a tall order, as you can imagine, but more and more providers' offices are calling themselves medical homes, and they have to satisfy certain criteria. And the government is really pushing, especially with the ACA, to have more primary care, patient-centered medical homes. But you have to meet certain criteria. So if a good primary care office, which already does all this, would be called a patient-centered medical home. And it's important to know because transition is one of the things they look at to see if they provide transition-related services and how they deal with the transition from pediatrics to adulthood. So this is a follow-up video of what a good patient-centered medical home would be like, and it talks a little bit about the medical home in general. So hopefully all adult offices are not like the one we saw in the video, the 10-second appointment. So in 2011, the journal Pediatrics, which is the biggest journal in the field of pediatrics, published a consensus statement about transition, and it's actually talked about how to do this in terms of best practices, financing, education, research. It was developed by an expert authoring group, including pediatricians, adult providers, family practitioners, community members, youth with disabilities, and it was reviewed by a large and diverse constituency, and it really provided very good structure based on age, starting at about the age of 13, on how to do this at the annual visit, and maybe perhaps schedule a separate visit for youth with complex medical needs because they require more time and it cannot be done in a preventive or well-child visit. And they also talked about how limited the outcomes research is, which means what is good, how do you measure good transition, or how do you measure successful transition? So there was a lot of talk about how we should do more research on how to measure. Is it from the family's perspective, the youth's perspective, the provider's perspective? Is it just taking care of medical needs? So there's so many issues that need to be addressed, but this is a really good paper for pediatricians and adult providers to use, and I've been sharing this across our healthcare system because it provides excellent guidelines. So how do you get ready for transition? Number one, I think you need to really start talking to your provider, your pediatrician, about when do you transition? It varies across healthcare systems. In some offices, the pediatrician is happy to let you stay in your 20s, perhaps in your mid-20s or late 20s. They might say, I think you might need to move on at this point. When you're in Kaiser, at 18, you automatically transition. You don't have a choice. They just assign you a new provider when you're 18. So it really varies. In UC Davis, it's kind of really depends on the provider, but most of the time, I think by the time they're in their mid-20s, they say it's time to move on. Some pediatric subspecialists will see patients up to their 50s, for instance, pediatric cardiologists, because they deal with all the congenital heart diseases, and adult providers don't get a lot of training on this because they don't see them from a childhood. So they tend to hold on. Sometimes they have patients up to their 50s. So it really depends on the providers, the subspecialty, and the healthcare system. It's good for offices to have a transition policy, telling patients about when they might be transitioning and how the transition process works. When you're getting ready for transition, it involves the whole team. So it's the doctors, the nurses, the patients, the families, care providers. And you also need to identify an adult medical home, which I'll talk about in a little bit. Also start planning early. This is a long process. It cannot happen overnight. So especially when it comes to teaching youth self-advocacy and how to talk about their own healthcare diagnoses, their medications, how do you make doctor's appointments, what's their past medical history, even a 5-year-old can be taught their diagnosis and their medications. You can certainly teach a 5-year-old, but what happens in pediatrics is the parents always speak up for them and they never learn to speak for themselves. So it's really important to teach youth this time you're going to tell your doctor your medical problems. When they turn maybe like 16, 17, you're going to call and make your appointments. You're going to call and get your refills. So it's really important if you don't give them the chance, they're not going to do it. So you have to be that person who pushes them to do this. There are lots of great toolkits. Autism Speaks, for anybody who has an adolescent with autism, has a great transitions toolkit for autism. It's an excellent resource. You also need to consider not just physical health, but mental health, reproductive needs, insurance needs, because insurance does change, especially for those on Medi-Cal. Insurance changes when you're past 18. You don't qualify for Medi-Cal unless you have SSI. CCS ends when you're 21, so that's another issue which many families don't consider. So it's important to discuss these things, perhaps talk to a social worker or a case manager about how you might go about changing insurances. Also ask for a portable medical summary, and do all of you have this paper on a portable medical summary? So I just wanted to give you this is something I created in our EHR system. Those who have it can pull it out. And it's basically a snapshot of all their medical problems. So it has their name, date of birth, it has their demographic information, unique needs, strengths, assets, assistive technology, insurance, all clinical information, including last vital signs, height, weight, all the immunizations, past medical history, what therapies they have, medical equipment, functional capabilities, what subspecialists they use. And this is a document which actually auto-populates in our EMR system, and most healthcare systems can actually do this. It's fairly simple to create in an electronic health record system. So most of this information actually auto-populates, and you can just print it out, just add in some of the more recent updates, and give it to the patient to take with them, either for their files, or if they go to an adult provider, they have a snapshot of all their medical history. And this is really helpful for families. So if a provider does not have time to do this, you can make one for your child or your family member, because this is a really useful thing to have to pass on to the adult provider. No adult provider is, when they request records from the pediatrician, they're going to get this huge stack or thousands of pages on electronic records. No provider has time to go through all that, I can assure you. So having this snapshot of all their medical diagnoses and their information is very helpful, not just for families, but also providers. So I strongly encourage you to get this going if you haven't done so already. So this is probably the most common question I get asked: how do we find an adult provider? I think a good way to start is to ask the pediatrician. I should also mention that if you have a family practitioner as your primary care provider, certainly you can stay on in family practice because they're trained in taking care of adults and children. But the important thing is to learn that the system of care, delivery of care might change, because you need to have the youth speak up more and be their own advocate. The youth provides their own consents if they're capable of it. They're the ones who make the healthcare decisions, and they should be taking a much more active role, even if you're with the same doctor. Another good way to find an adult provider is if you're the parent or the caregiver, it could be your doctor. You already know that doctor. You can just, and they're probably familiar with your family or your child's medical condition. And you could just say, hey, would you mind taking my son or daughter on as a patient? And they're probably going to say yes if you have the same insurance. Family practice doctor is another good person to transition to, because they are a med-peds doctor, so they're people who are certified in both internal medicine and pediatrics, so they're good choices. Ask around, ask friends, family, network, and ask about, what you're looking for is not somebody who's an expert in or X or Y condition, but a doctor who has good communication skills, who's interested in learning. So say if your child has Down syndrome, there are excellent guidelines from the American Academy of Pediatrics on how to take care of children and adults with Down syndrome, what you should be doing. And you can print out that article and give it to the adult provider, or ask the pediatrician, do you have a summary of what my adult provider should know about? And you could be the one handing it to the adult provider. The important thing is to find someone who's interested in learning and who's got good communication skills, who understands your family. That's, I think, more critical than finding an expert in a certain condition. And obviously you want somebody within your insurance network and within, in your neighborhood. The last option is to get a list from your insurance company and kind of shop around. But that's a more complicated way of going about things, so I would suggest the first four. Okay. Now we'll go back to Becky and follow-up video on how this can be done in a much nicer way. So part of the reason I wanted to show you that video is to give you that perspective of how important communication is. If you just send over a stack of records, that's not really good communication. So it's really nice when the pediatrician takes the time to call or even send a message on the electronic health record. Now we can pretty much message anybody within the same healthcare system and say, hey, I'm sending over this patient, these are the things that I'd like you to know, or have a look at the summary that I sent over. Even if they don't have time to make that call, you can at least communicate by staff messaging on the electronic records. And nowadays, most big healthcare systems have that capacity to message other doctors. So I think phone calls, FaceTime, electronic messaging, email, all those are great ways to communicate. So I would strongly encourage you to ask your pediatrician to say, can you please just call or message the adult provider just to let us know, let them know what the condition is and a little bit about our family or patient. So I think that's really critical, and when I teach medical students and residents, I really emphasize a lot on how important it is to have that direct communication instead of just a stack of paperwork. I wanted to talk a little bit about conservatorship. I know this is a big issue with many of our intellectually disabled clients and patients. That conservatorship is often used synonymously with guardianship, but the correct term is really conservatorship. It's a legal process which gives one person the power to make decisions for another person when they don't have capacity. And in California, there's general conservatorship. Limited is only for those with developmental disabilities. And then there's the Lanterman-Petraeus-Short Act, which is for patients with complex mental health care needs, like, say, schizophrenia or psychosis or something. So it's really a family's choice whether they want to do conservatorship, but it helps providers a lot when they have that paperwork in process, because say you have a 20-year-old who has an accident or something, and then who's really they're supposed to make their own decisions, but if you don't have conservatorship papers, it puts the providers in a bind sometimes as to who is making the decision for them. People in the regional center often get calls about unconserved adults, and this is somebody they don't really know very well, so it's usually the medical director or their designee who's making these decisions, and it's not somebody who's their patient. So I think if you have a family member or a caregiver who's going to be with this young adult for a while, I would suggest that you go ahead and do the conservatorship, and it could be limited, could be only for healthcare decisions. Other thing with insurance issues, with the ACA, you can stay on with your parents' insurance till the age of 21. 26. There's no pre-existing condition denial, no annual lifetime limits. Medicaid has also been expanded. For instance, now Medicaid will provide dental benefits and things which we never had before for adults on Medicaid or Medi-Cal. Access to preventive care with no copays. So these are all new things with the ACA, which are all good things, I think. For those who have SSI, your benefit changes at age 18, so they actually have to redetermine eligibility at age 18. And you also have to, this is something I learned when I was working in this field, is that you actually have to report wages after the age of 18. So say somebody leaves you an inheritance, an elderly uncle or somebody, that's actually counted as wages, and you may lose your benefits because of that. So all these things have to be taken into account. If you don't have SSI, you cannot really stay on Medi-Cal, so you need to apply right away. So this is something that needs to be done well before that age when you transition to 18 years. So you need to do this in advance. And a lot of our non-English speaking families or low-income families really struggle with all these issues because they don't know how to work the system and how to get all this paperwork in on time. So there are agencies in the community which can help them with this, and it's there in the list of resources for you. Again, those who have CCS, that ends after 21, so that's important to know as well. So disabilitybenefits101.org is a good resource online. So this is actually a topic which is it's so confusing. I myself have a lot of trouble with this. I just see patients, and I have been trying to learn more about this, but it's extremely confusing even for providers, and most providers don't really want to deal with this because it's so complicated. It really is, and many social workers themselves don't really get the full picture from what I see. So you really need somebody who knows about this stuff. As you all know, education transition starts at age 16 with the school IEP meetings where they're supposed to do an ITP or individualized transition plan. And this is supposed to have measurable goals and outcomes as to what your post-secondary education is going to be like. Do you get vocational training, employment opportunities, community integration? Again, unless you address this, it's not going to happen. And it's also important to discuss this with providers, because providers really don't know many doctors don't even know what an IEP is or an ITP is. They really don't know. I know because I work in this field and that's what I do for a living, but honestly, I didn't have a very clear idea when I was a primary care pediatrician what exactly they do in these meetings. I just knew what the term stood for, so you have to be the one educating the providers. And you want the youth to advocate for themselves, talk about what they want to do, once they graduate from high school. And we know that they can stay on in public school till they're 21. So. Some resources on vocational training and community integration. This is the time when the regional centers actually come into play. They're actually very eager to find out more. I work part-time for the North Bay Regional Center in Napa, and having been working in the regional center, I realized there's a real need to educate people at the regional center too, because a lot of the service coordinators are very young and they don't have a lot of experience. But they're really eager to learn and they want to know more. So you might be the one educating them about what you want and what you need, and especially about healthcare conditions, because they really don't have a lot of knowledge or expertise in this area. This is one area which providers absolutely need to address. There's this perception that children with intellectual disability or physical disabilities are sort of asexual or childlike, and providers don't often understand that they have the same hormonal urges and they are attracted to the opposite sex or the same sex, or they, but they often don't have an appropriate way of interacting with the opposite sex, and sometimes they get into trouble for it. There's also a very high risk of abuse for young girls with intellectual disability or cognitive disabilities. It's a horrifyingly high percentage, and so you need to teach them about safety. I know the regional center has some courses every year which they hold for about reproductive needs and safety for adolescents with special healthcare needs. So that's a good thing to find out about, or any talks in the community. You also want to teach, I've had several parents of young adolescent girls with cognitive disabilities ask me about sterilization and how can we protect our daughter from getting pregnant or being abused. Sterilization is not legal, so that's not an option, but you certainly want to encourage them to talk to a GYN doctor about contraception if they're really worried about their safety. Because I myself in the Mind Institute have seen several women who are intellectually disabled who have gotten pregnant and their child has been either taken away by CPS or is being uncared for, not for any fault of the parent, it's because of their limitations. And I've seen this many, many times in the Mind Institute. So this is not something that's written in the books, it's definitely happening. So you want the pediatricians often don't talk about this, so you really want to make sure that this is a topic they address and talk about options for contraception and safety. So in our EMR system, I actually created this for providers to use, and it's all yes-no options. So this is just a checklist on healthcare transition readiness. Have they identified an adult provider, specialist, health insurance, guardianship forms, educational plans, living arrangements, so things like that. So the provider just has to, this is a checklist for the providers to use so that they can go over the list and make sure all these things are addressed by the families. This is a checklist for youth. Can you identify your medical diagnosis? Can you name your medications? Can you identify your medical home? Who's your doctor? We have several adults who don't know who their doctor is, so it's important for both the family members and their child to know who their doctor is. Can they schedule appointments, pick up refills of medications? Can they have a one-on-one dialogue with their provider? Can they give consent? Can they talk about medical options? Say if you have an elective surgery, what are the options? How do you advocate for yourself? So this is a checklist for providers to use, and it's in our EMR system, and it's fairly easy to create. So if there are other providers who need this, I'd be happy to share this with them. So my take-home pearls: start transition planning early, teach youth self-advocacy skills early. So don't wait till they are 18. Start teaching them to speak for themselves, advocate for themselves. talk to adult providers and subspecialists, ask the pediatrician to communicate with them, create a portable medical summary, like the one I gave you a sample of, discuss the office transition policy with the doctor, and for youth with disabilities, discuss things like changing insurance needs, what community supports are there, what is the role of the regional center, educational issues, vocational skills, conservatorship, and reproductive needs. The other issue I didn't touch upon was mental health needs. So many youth, this is a turbulent time, as you know, adolescence is a turbulent time emotionally, and then on top of that, if you have something like autism or anxiety or depression, things can really be difficult for both families and for the youth. So it's important to talk about how they're feeling and what their mental health needs are and address those needs. Again, there's a perception that, oh, you have a disability, so they don't look at the picture of how they might be feeling emotionally. And it's important to talk about how not just the youth, but also the families feeling. Many families are overwhelmed and tired, and they need to get some help too. So it's another thing which doctors should be talking about. So my take-home message is all youth need education, guidance, and planning to assume responsibility for their own healthcare and well-being into adulthood. So this is my list of resources. So the first resource, gottransition.org, is a wonderful, wonderful resource. It's packed with information. There's a tab there which says for youth and families. If you want any information on transition, this is the website to go to. It compiles resources from all the resources across the country, and it has research papers for those who want to read that. It has resources for families. It has videos and webinars and excellent, excellent website. It's like the best website on transition. But there are lots of others, but I don't want to overwhelm you with too many resources. Just use that one. And then I wanted to say a special thanks to the USED staff, to Robin Hansen, who's a professor and my mentor, and to my own families, and most of all, to all the wonderful providers, staff, patients, and families at the Mind Institute. And I'll let Nicole talk now.
My name is Nicole. I am lucky enough to have my son David in my life, and he has been such a huge experience for me, a way that he's brought in things in my life that I wouldn't have normally encountered. Things that have helped me with my other children coming through. I have 5 kids total. So some questions that come up with transition often are, where do you start? It's a challenge. What other issues do you need to consider as you're moving through this process of transition? Again, how do you choose the right provider, and what resources are really out there? You may not have a medical home, so then what? How do you kind of work through this process, and how do you really figure out what's going to work for your child or adult now? What I've found is that there is no magic age for transition. Start early. We talk about medications. We talk about being able to just name off your birthday when somebody asks you. How are you going to answer when a provider talks to you? What's appropriate? Are you going to grunt at them? Are you going to growl? We've done a lot of different things. The biggest thing with my son I found is I need to ask him. I can't assume that this is what he wants. We need to talk. We need to have real conversation. It's all about collaboration. It's not about telling him what's best for him or what to do or how he needs to figure it out. It's about helping him figure out what it is he wants. Now I can tell you, my son does not know. His answer is, I don't know, or what do you want to do? Nothing. That's always the answer. So my job moves from parent to coach. Okay, how am I going to coach you to be able to answer that question for yourself? What's that going to look like? How can I ask you questions or bring things about in a way that's not going to be overwhelming for you to face? My son gets very anxious. He gets very anxious about, you ask him, what are you going to do in 5 years? And complete shutdown. You talk about what things you enjoy, what you like to do, how you like to spend your time. You kind of maneuver over to maybe some other things that you've tried but you're not really sure about. And then you kind of bring it all about with, well, maybe we can turn that into something that you could sample. It's not about making a life choice that you're going to be stuck with forever. It's about finding little things that you can pick and choose that are going to be helpful for whatever it is you decide to do. And it's going to change, but we're constantly having that conversation. Assessing the needs, I in my handouts that were out front, there was a sample of, this came from Got Transition, it's an amazing site, but they kind of ask those questions. What do I already know? Ask those questions. Where are we at? What do we need? And target those areas of need. I'm not going to beat a dead horse. If he's got something, he can do his birthday. I'm not going to practice that every time, but we're going to pick something different to focus on each time. We're not, and then we can chain it together. It doesn't have to be just okay, you have to do it all at this first interview and here we go, because you're going to set yourself up for failure. So it's not you writing it down, it's them writing it down. That's probably one of the biggest keys. My son makes his own lists, and he's amazing with sticky notes in his pocket. He's got a list. He can get through what he's supposed to do with that list. So it's at their level, what they need, and how to support them. Parent to coach, collaborative problem solving, whatever you want to call it, parent to ally. It all gives the same empowering statement of they have choice and they have a voice of their own that gets heard. So some of the checklists that you can go through, there's different ones. The Got Transition website had a great one. Warmline had a really great one, talking about just some things to consider. Looking at those skills levels that I was talking about before and turning them into collaborative, teachable moments. We work with ABA. He has an ABA provider that teaches him a little bit more about how to be out in the community. Well, one of those things we can practice is how to answer somebody with something other than or I don't know, or do you want to try this? No. That's the immediate answer is no. And eventually, people stop asking you if you want to try things if you answer like that. So we want to encourage more invites and more socialization. So of course, we're going to find other ways of doing it. Going out into the community with a speech therapist. He has speech therapy services, and he's able to take that out into a bakery, and they do some practice scenarios. He's able to take that into the grocery store. What's that going to look like? Tailored support services. Who's their provider? Who's working with them all day when you're not? Who's going to be that place, that person, and collaborating with them to make sure that they're hearing your child's voice, your adult's voice now, as well. Help them collect the information. You've probably already got a binder that's yay and a couple of cabinets full of the information. We all collect it. I broke my back carrying those binders from appointment to appointment, which brings me to something that I didn't add on my slide. Well, maybe I did. Go electronic. Scan it, carry it in a zip drive, hand it to your doctor, say, here you go, what do you want? I can help you find whatever you need on here. Using that portable healthcare summary, hit the highlights. What are the biggies? Make sure that those are outlined somewhere. For my son, it's about getting the information in a place that he can access it and use it. So we may print out a page that he's going to go through, and we're going to talk about, hey, this is the high points I want to hit. This is what's important to me to have addressed at this appointment. You have another handout about must-have papers. It should be in your printouts. That's amazing. It talks to you about just all the information that's relevant for your adult so that they can start to make informed decisions on their own. They're not going to know how to make those decisions unless we help them and we teach them how. And that's the key. As a parent, I think my job is to teach my son how to make good decisions and how to pick people in his life and his community that are going to have his best interests at heart. I may not always be with him. I need to know that he has the skills to make good choices and to find the supports he needs, whether that's a family member, whether that's a care independent service coordinator, whatever that's going to look like. I want to know that he can make those choices. I'm not going to be able to always do that. If you don't have a notebook, start one. Like I said, digital, Google is my friend. I use Google Calendar. We schedule all the appointments. He can pull it up on his phone. He knows what he's supposed to be doing, when he's supposed to be doing it. We can we've just recently started he attends college, so his college information, like what's due, assignments, what he should be working on, and he can get reminders. So he's completely independent. It's not me nagging. I'm not the mean, evil mom. Well, you know what I mean. You still are. But it's less intrusive to his individuality, and that's my goal. Less is more. My goal as a parent is to be obsolete. I want him to be, it's not going to always look like that. There's going to be times where I have to step in and say, hey, let's talk. We need to really figure this out. But really, if I do my job well, I can enable him to make good decisions, and I'm there because he wants me there, not because he has to have me there. And that's going to look different for everybody. Everybody has different needs and different abilities, and you just go as far as you can with what you have. Let's see. So choosing a provider. So Dr. Mahajan did a beautiful job of going over. I would second everything she has. I would only add maybe social media. Ask other parents. You're all friends with somebody who knows somebody who has a kid with special needs. Who did they go to? Where are they transitioning? You're not the first, and you won't be the last. Talk to your primary care. Your primary care is going to have good information sometimes if they're connected. Sometimes, in our case, we got a letter saying, here's your new doctor. Suck it up and deal. And, I mean, it wasn't quite like that, but it felt like that. And so for us, we ended up actually going back and saying, no, I don't think so. We're going to go ahead and do some interviews. We want to talk to some people, and we want to make sure we're getting what we need and what he needs. Honestly, psychiatrists stayed the same, so they transitioned with us. Primary care is just kind of that gatekeeper putting the orders in, but it's still important, and it's still helpful for addressing his needs as he does have more health needs. We've been very blessed that he's been fairly healthy, so we haven't needed as many primary care visits, but that won't always be the case. So making sure that we have somebody who is able was very important for us. So asking the questions, you go in there, we wrote them out on a piece of paper. Have you ever had a patient with my diagnosis? How did you deal with difficult situations? What's your support network? Where are you going for information and support? Do you feel confident that you can help me with my unique issues? Is your office accessible to me? If you're in a wheelchair and they don't have the right kind of equipment, or if you have different medical equipment that needs to be considered, are they prepared for you? I mean, the goal is that both parties need to be comfortable and safe during the visit. So that means the provider as well as the patient. Do your office visits have enough time to cover my needs? That's big. We take our time going through it. It doesn't all come out just like that. It would be lovely if it did, but reality is it takes some time to draw these questions out and to feel confident and comfortable enough to ask them. So are you willing to schedule a little bit longer for me? I know in some clinics you can get a half-hour appointment instead of a 15-minute follow-up. In some clinics you can get an hour. So you ask. You figure it out and you ask. My son had his own concerns, and of course, they needed to be addressed, so he asked his as well, how the doctor felt about Star Wars, and whether he could bring toys or video games with him, and as long as we're on the same page, we're good, and it went well. So it was a positive experience, and so we picked our doctor. He's actually gone once without me, with a different care provider, which was huge. He still can't tell you his medications. They still have to be typed out for him. He actually types them before he goes. Actually, it's not me. But we talk about allergies to medicines. He can answer kinda sometimes. Sometimes he forgets, and we have to go back to the paper. And we write down. We target 3 questions. What 3 things are we going to hit this visit? What's important to us? Everything else we'll share. We want to be respectful of the provider's time as well. But we get those 3 questions answered. So other considerations. Like I said, Google Calendars. Let me tell you, you can work with service coordinators and providers. You can work with your adult. You can keep up. So when he's entering data, it's coming in on your phone. It's great because I know, hey, you're supposed to be in class. Why aren't you there? Where are you? What are you supposed to be doing? Or you told me nothing, but you have a final tomorrow. Why aren't you? Don't you think, just playing mom. Online health records, amazing too. Being able to email back and forth and access the providers. A lot of times we can sit together or we can talk about it over the phone and I can be typing or he can be typing and we can talk about it over the phone. So we don't have to be right with each other, and it can be 10 o'clock at night. It doesn't have to be during business hours, so it makes life easy. Let's see. This is important. It's hard to see. I understand that. You should have a copy. This is what is called a consent for release of information. As a parent, if you don't have these and your adult is now of age, or your child is now of age and an adult, you need to make sure you have this. Because if you're providing any level of support and they're going to talk to you or give you any kind of information, you have to have it. They won't talk to you. Even if it's just basic stuff. If your adult isn't scheduling the appointment yet, you're kind of building up to that, and but they're doing med lists or whatever, the staff won't be able to talk to you, and it'll be frustrating. And you'll find that you have a different one of these for almost every group that you get support from, whether it's your Alta Regional person, whether it's Medi-Cal, whether it's your doctor, your psychiatrist. His psychiatrist wouldn't even take a power of attorney. She required a special, specifically with her name on it, giving that access. She says power of attorney is only good if he can't answer for himself and he can talk to me, so no. And so we had a lot of fun with that. Anyway, sign the paper. So the big picture is to make sure you authorize. So in this case, it's a little different. But you authorize that provider to speak to the family. And it's important to have that distinction there, because if you put it backwards, they won't honor it. The other thing to consider is you can include or exclude information. So it can be very specific and tailored to what you need. You can include drug and alcohol stuff, or you can stay out of that. That's not my business, that's your own. Genetic issues, same thing, you have the right to stay out of it. It can be medical, it can be mental health. You can specify it down to the visit that you want them to be able to talk at and nothing else. So there's a lot of freedom there. If you don't specify anything, you get general access, and it's basically lasts for a year. And so each year you're renewing these. Again, if you need support and you say, hey, I need mom to call and make this appointment because I can't do it today, can't be happening if you don't have the paper signed. It's very important. So that's important too. Also dealing with referrals. There's different health systems that have referral centers, and sometimes you have to have it directly to that referral center. They won't honor a general one. It really depends. It's person to person as to what they'll accept. So just be prepared. So I'm going to share a little personal story. Nobody tell my son. We had our visit with our primary care, his primary care, the first time, and it was actually going pretty well. We hadn't had a lot of support with transition. Not a lot of information given to us. We got a letter in the mail saying, you're out of here, go on over. We'd done our interviews, we picked our new provider, and we were ready. We had our questions. We knew what we needed to do. My son, on the other hand, was a nervous wreck. I mean, I was a little nervous, I'll be honest, but my son was a nervous wreck. He had forgotten to bring his phone that had stayed at home. He forgot which he plays his games on. His Star Wars Lego guy, forgot that too. It was in the car. And I said, oh, we're here, you can get through this. You got this, be strong. Well, everything was grand until we got to the MA, who brought us back to the room, and we did vitals, and that was okay, and we got through. She handed him this form to fill out. It was a screening for depression. Well, there's a difference between temporary, I'm upset because I don't have my thing, and more permanent, hopeless, I'm going to hurt myself. And it took a lot of explaining to get through that appointment for the provider to understand the difference. So be patient with yourself, with your adult child, with the provider. I learned a lesson, valuable lesson. You can't always prepare for everything, and it's all in how you approach it and you deal with it. We were able to work with the provider after a lot of explaining and discuss some of the areas where we've had problems in the past. And we turned it into a positive, but he didn't have as many coping skills as I thought. So it was eye-opening for me to look at other needs. Okay, we need to address this so that when this happens again, because it will, how do we deal? How do we move forward? So it was an interesting thing. I've never had, as a nurse, I've never had somebody fill out a form saying they were completely hopeless and depressed and had no interest in anything because they had no toy. I worked in the ER for almost 5 years before I came here. Hadn't seen that before, but I see it with my son. So it's interesting, and you get through. But some resources, a lot of them are the same as Dr. Mahajan has given us. There are some amazing videos out on the web as well, on the Mind Institute website. There's Got Transition, Warm Line. Hadn't really seen some of because of the way they sit in the websites, I hadn't noticed them. But as I've been clicking through a little bit more and looking, I found some of these great checklists. There's some other things that are out there, other versions of the healthcare questionnaires and health issues checklists. So if you need other formats, if one doesn't work, you find another one that works for your situation. And again, thank you to the SED and to Dr. Hansen, Dr. Mahajan, wonderful providers, my son, and I appreciate your time tonight.
I apologize, I don't remember, I think it's, someone said about Medi-Cal needing to, ends at 18, Medi-Cal or Medicaid, or which program that was, and getting SSI started in advance.
Yeah, so from what I understand, Medi-Cal or Medicaid usually ends at 18, but if you have SSI, you can stay on it, but you have to reapply. It doesn't automatically continue past 18, so you really need to reapply, and you need to do that well in advance because, as you know, things move slowly. So, okay.
Sorry, I can speak to that one. We live that. They won't actually take the application until the month that they turn 18. So you actually can't submit it until right then, and it does feel rather last minute. It doesn't mean that they're not going to not continue services. I believe there is a requirement to continue over until the new application is considered. But we definitely had to go through that one.
Okay, yeah, so.
Do they notify you of that before that? Like, do they give you a heads up, hey, in 2 months, your kid's out?
No, it's a surprise. The gift that keeps on giving.
But I do know that you don't suddenly lose it the day you turn 18, so that's good. At least they keep the services. So. But I know many families who struggle to this, particularly I would say non-English speaking families, and they really struggle through this because it's so complicated and they don't get a lot of help from anybody.
Well, and just to let you know that also I work for CCS, so that's where I'm from. And that if you are not in Sacramento County and you are in another county that has a partnership, if your youth is being followed in another medical facility for special care, such as Sutter, Mercy, Shriners, wherever, but you're adult, that you're looking at going to adult care at UCD, that youth must be authorized to UCD prior to turning 21 or prior to leaving the pediatric organization that they're being followed by, because otherwise partnership will not go ahead and make payments to UCD, because they're like little children and they fight back and forth. So it is important, and it is something we try to push all the time. And our biggest struggle right now is physicians that follow youth at like Shriners and know they're going to see them at UCD when they're adults, or they're going to transition to adult services. And Shriners has drastically changed their methods to keeping youth. They used to give them up at 18 pretty regularly, and now they're keeping them until 21. So if that transition is not made to UC Davis prior to turning 21, there's no guarantee partnership's actually going to pay for their medical help.
So does CCS help with this process?
Oh, it's a major thing right now. I mean, that's why I'm here, because it's a major thing in Yolo County where I work to help our families be better prepared. Because as an organization working with youth, you want to make sure that child and that youth is getting the best medical care. That's why CCS is here. And so you remind families all the time, you know, get to your appointments. We've authorized, call and make appointments, be pushy, get your appointments. Oh, your medications, oh, your supplies. Stay up on things, keep things. But then when that youth is starting to turn 16, 18, and 20, those families don't start taking back over their responsibilities, and we're trying to give it to them. And their natural thing is, well, you've always been there, so you're going to continue to be there. No, the minute your child or young adult turns 21, we're not there. Legally, we can't assist you anymore. And trying to get families to realize that you have to start taking care, and if your youth is capable, they need to start stepping up, and you need to be coaching them on how to get through the medical process, because it's very, very much needed. And our biggest concern is pediatricians don't like to give kids up, and specialists don't like to give kids up, because they've built a very, very warm relationship with family and client. So I want to thank you for doing this tonight, because to me it's a very, very important thing.
Thank you.
I was very concerned about the problem of the exploitation or victimization of, of the girls sexually. I think there's a long history of vulnerable teenagers being taken advantage of in that way. I'm losing my voice for some reason. And I would like to know what concerted efforts are being made to address that problem.
I think people who are working in my field of developmental pediatrics and dealing with children and adults with disabilities are certainly interested in this topic, but I don't think it's addressed enough in primary care, and that's the place where you really get help for these things. You know, these are things that the primary care doctor needs to bring up if the family doesn't, and talk about how do you advocate for personal safety, what kind of contraception can you use, how do you keep your young adult females safe. Those kinds of issues are not talked about enough, and I don't think there's any concentrated effort on a national scale being made, but I think there is increasing awareness and people are starting to talk about it, but I think there's way more that needs to be done.
The numbers are not just regarding women. The numbers of males with developmental disabilities who have been sexually abused is strikingly high as well. For women, the numbers go between 70 and 80%. For men, it's above 60. So the numbers are quite high. There are some good providers in Sacramento, Dave Sincelli, and several other people do sexuality awareness trainings if you contact me at the Resource Center, I can provide information about people who are doing work in that area. I have a question about the patient-centered medical home. I had never heard of this concept. What's the process to find providers who are using that model?
I think it's, I think the AHRQ, the Agency for Healthcare Quality, they actually have a list of criteria which people use. I think the best way is to really ask, do you qualify as a patient-centered medical home, to ask your doctor's office, and you can ask, what are the efforts being made. It's not, you don't get a certificate as yet, but I think more and more primary care offices are moving towards that model, and certainly all providers in the primary care health field know what a patient-centered medical home is, because it's something that's talked about a lot in primary care.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.